Well, thanks so much for the opportunity to deliver the 68th annual Lucy Squire keynote. I'm really thrilled to be a part of your meeting. My only regret is that we could not be together. And I sure hope that each of you is staying safe and sound. Who would have possibly thought that we would be in this position in the summer of 2020? Special thanks to AUR for this privilege, and special thanks to all of you for carving time out of your busy schedule for this program. I'm really very appreciative of your time and attention. Let's take a moment to think about Lucy Squire and her amazing career. And it's interesting that Lucy and I share some background. So she, of course, was a graduate of what was called then the Women's Medical College, which is in suburban Philadelphia. Then that turned into the Medical College of Pennsylvania. Then that was subsumed by Hahnemann, and now all part of Drexel University College of Medicine, a neighbor to Jefferson in downtown Philadelphia. But Dr. Squire also, in her first faculty appointment, was at the University of Rochester School of Medicine, and that's my alma mater. So we have some interesting ties in our career. So she sounds like she was an amazing woman. And I would just add, since I'm married to a doctor and have one daughter who's a doctor, I totally get it. And thanks to Dr. Lucy Squire for paving the way. Okay. So the title of my time with you today is Population Health. What's that? And why do we need to shut the faucet and stop mopping up the floor? This is more relevant now than it was when we were scheduled to be together back in April of this year in Philadelphia. So here's the outline for our time together. I'm going to try to make sort of three main points. First part of our time will be a discussion, which I hope will be familiar to most of you. How did we get in the jam we're in? And I'll try to focus on the system level issues and, as appropriate, make reference, of course, to radiology. So part one, how did we get in this mess, and what's the size and scope of the problem that we're facing? Part two, what exactly is population health, and why is it more important during this pandemic than ever before? And then the third and final part of our time together, I'm going to look into my cloudy crystal ball and give you Nash's view of the future. And I have some help in advancing the slides, so please, next slide. So it turns out that the American College of Radiology has been interested in population health for some time. You might remember this cover story from just a couple of years ago. And I had the privilege of being interviewed by your colleagues in radiology. It's the first time we appeared in the bulletin, and the first time we were introducing the concepts of population health. So we won't give up our thunder quite so easily. We'll wait till part two when we actually define our terms. Next slide. But I think it's very important here in part one to set the stage. And if you look carefully, let me read this to you. We'll give you the abridged version. All integrated delivery systems are accountable to the public for their degree of success, like Jefferson Health, our 14-hospital system in Philadelphia. And if this initiative isn't taken by people like you and me on this program, it will be taken by the lay public. Now, I didn't exactly say it the way it's printed, but the exact citation that you have in front of you is more than 100 years old. And this was at the formation of the American College of Surgeons at the famous Waldorf Astoria Hotel on Park Avenue in New York City during the First World War. How prophetic that it was at the height of the Spanish flu epidemic, right? More than 100 years ago. In our city, Philadelphia, not New York where this was done, but Philadelphia had some very interesting and dreadful complications related to the flu pandemic. More about that later if we have time. Main message, we've been talking about the issues here of transparency and accountability for a century. And we're going to come back to these issues of transparency and accountability in the third and final part of our time together. So I want to get these words into your head transparency and accountability for who we are and what we do every day, regardless of our specialty. But in our case today, of course, our radiology colleagues. Next slide. So this is a history question, and we'll come back to this at the very end. Let me give you the context here. This is the New York City skyline in 1918. The New York City skyline in 1918, and this is the launch of what was to become a world-famous battleship. Here's a hint. It's the same year, 1918, as the formation of the American College of Surgeons and their commitment to transparency and accountability. So take a careful look at this fascinating ship, and we'll come back at the end and I'll ask the question and hopefully someone will have the answer. What is this ship? And what role did it play in the United States history not too many years after its launch in 1918 from the famous Brooklyn Navy Yard in New York? Okay, next slide. So this fellow ought to be recognizable to everybody in our program today. And remember, we're here in part one and we're answering the question, how did we get in the jam we're in? And of course, this is our former colleague, Dr. Ernest Codman, C-O-D-M-A-N. Ernie was a Boston Brahmin surgeon practicing at Man's Best Hospital on the banks of the Charles River in Boston at around the same time as the American College of Surgeons was formed and that ship was launched. And Dr. Codman had a fascinating idea as a general surgeon. He kept a file card that he wrote notes to himself on every procedure. And these notes were his self-evaluation as to how he could have done a better job. And he brought this collection of file cards on all of his procedures in order to improve surgical outcomes and have greater transparency and accountability. He brought these file cards to the members of the Massachusetts Medical Society just after the First World War. And he suggested to the members of the Mass Medical Society that he would like to publish his results in, of course, the journal they're responsible for still today, the New England Journal of Medicine. Well, colleagues, you can imagine that the members of the Massachusetts Medical Society were not too thrilled with Ernie's proposal to publish his findings on how he might improve and make recommendations to colleagues as to how they might improve. In fact, they were so scared about his work that they banned Ernie for life from membership in the Mass Medical Society. And despite the fact that he was the scion of a Boston Brahmin family, Ernie died a pauper in an unmarked grave in 1940 on the eve of America's entrance into the Second World War. Hence, the Joint Commission's highest quality prize in the 21st century is named after Dr. Ernie Codman. Next slide. Well, colleagues, we had to wait nearly a century for Dr. Andy Warshaw, at that time chief of surgery at Man's Best Hospital on the banks of the Charles River in Boston, to take up a collection to find Ernie's unmarked grave and to create a tombstone in his honor, making front page news in this story in the Boston Globe, honoring a once scorned voice for medical openness. So colleagues, what's the message here? It's a great history lesson. We owe a lot to the bravery of Dr. Ernie Codman and all of his subsequent colleagues who were committed to an era of openness, transparency, and accountability way before these were popular notions and way before, of course, Dr. Lucy Squire. Okay, next slide. So regrettably, in the last few months, just before the pandemic, there have been a series of very embarrassing and sad and very poor quality outcomes. I'm not going to pick on individual institutions, but certainly you can read here. And if you were following the news back in the spring of last year, you know that there was some rather pernicious issues at very famous institutions where there were, in this case, some dreadful and totally inappropriate conflicts of interest. contributing to the public's view that, we're on the take and that we're not transparent and we're not accountable. Next slide. You were probably also following at around the same time a dreadful issue at a vaunted academic medical center in the southern part of our country, and I won't name names here, but it was so sad to learn that a physician wore a wire and recorded the findings of the Hospital Quality and Safety Committee, sent a transcript of this meeting to the New York Times, which then conducted a deep investigation of the duplicity and chicanery that went on at this famous Southern academic medical center attached to an outstanding medical school, where it was pretty clear that folks knew what was wrong and were fearful of reporting, going up against the authority gradient to say, hey, wait a minute, we're not transparent and we're not accountable. Main message, if you think that it all ended with Dr. Codman at the end of World War I, regrettably, you are wrong. And even just a few months before the pandemic, nationally, we had some dreadful quality and safety challenges. Next slide. Well, this is in our own newspaper here in Philadelphia, and I won't go into the details, but sadly, this is a somewhat pathetic headline: wrong patient gets kidney, but all's well, thank goodness. But colleagues, I'm not going to dwell on this. You and I understand that the quality and safety priorities, sometimes we have lost sight of these. And it is important here in part one that we understand the complex nature and the systems nature of what we do, particularly relevant for a radiology audience, because you're all part of complex systems with complex technology. Next slide. So let's take even another step back here in part one. How do we get in the jam we're in? And I love this teaching slide. This is the cover of an old Business Week magazine, which emphasizes for me several major take-home messages. Let's go through them quickly. So first of all, it's sort of a dreadful cover. Here's a doctor on a roulette wheel, and I get it. It's rather disheartening. And when you read the cover story, medical guesswork from heart surgery to prostate care, you and I don't know which treatments really work. Sadly, this is true. Meaning, look, we know that we have grade A evidence, randomized controlled trial evidence for about 1/5 of what we do. 18% of the time, according to the work of David Eddy over decades, 18% of the time, plus or minus 2%, 1 out of 5 times we have grade A evidence at the bedside. The rest of the time, you and I know we call that the art of medicine, based on our training and experience, and the more of both, the better. But colleagues, from a evidentiary basis, we're in a jam that we often don't have the best available evidence when we need it, and it oftentimes doesn't even exist. On top of all that, the way our nation has health insurance connected to where we work makes it even more challenging, because we're the only nation in the Western world where employment equals receiving health insurance. Well, here we are, almost 140 days into the pandemic, with 13% national unemployment, including among physicians, and how sad it is that folks have to worry that if they did get sick with COVID-19, how would they possibly pay for it? Main message of this slide: yes, the evidentiary basis is poor. Every experienced doctor with enough gray hair or no hair knows that. And yes, we have a quirky system unique in the Western world, tying employment and coverage together. Another part of the jam that we're in. Next slide. Well, the public is wise to aspects of this, and regrettably, Mrs. Nash and I are now regular readers of the AARP Bulletin. I am 4 months away from Medicare, so I'll let you do the math. But the cover story of the AARP Bulletin is telling, right? Doctors say skip these tests: PSA screening, routine electrocardiograms, bone density scans. Here's the message, colleagues. At this very moment, while you and I are working together here in this wonderful program honoring Lucy Squire, while we're working together in Jefferson Health and in your institution, inappropriate and unnecessary tests are being conducted. I'm confident of that. And it's not a mean-spirited, pernicious issue. It's just that one person's unnecessary test, preoperative EKGs in healthy people going for hernia repair, one person's unnecessary preoperative tests, screening chest x-rays in otherwise healthy people doing ambulatory surgery, those unnecessary tests, those waste, that's one person's income stream. So another aspect of the jam that we're in is this crazy patchwork quilt, pernicious, the more we do, the more we get paid payment system that leads to unnecessary testing, finding the incidentaloma, and all the rest. I'm not pointing fingers. All I'm saying is the best brains in the business agree that about a third of what we do has no value and can sometimes lead to not only inappropriate testing, but as we chase these findings, harm can occur. Next slide. So I think we need to talk a little bit about waste in the system, and I didn't make this up for sure. The best brains in our business from some of the most important consulting companies with physicians at the helm have established a nomenclature for waste. And I concur that about a third of all of our spending, and this is work by William Schrank and others in October of 2019 in JAMA, which is repeated work by others decades ago, but the message is as follows. About a third of what we do is of no value. We call that waste in the system, and it has three categories. You could follow along with me. Behavioral waste, we'll come back to that, individual behavior, lack of exercise, poor nutrition, and so on. Then there's clinical waste, duplication, unnecessary testing. And then there's operational waste, constant questioning, the electronic record doesn't work, it's mainly set up as a billing system, you get the idea. Three types of waste: behavioral waste, clinical waste, operational waste. Taken in total, about $1 trillion a year. 1/3 of total healthcare spending is of no value. Wow, not at your hospital, not at mine, but everywhere else, I think I'm pretty confident that Will Schrank is right, writing in JAMA this past October, about a third of what we do is of no value. Of course, high value care is another part of work going on in the American Board of Internal Medicine and the American College of Physicians and their program Choosing Wisely. This has been going on for more than a decade. And we've had lots of very smart people trying to evaluate what's of value and what's not. Sometimes it's in the eye of the beholder or the payer. Next slide. So other experts who have looked at this, including this slide that I borrowed from the great Dr. Brent James, member of the National Academy of Medicine, one of the authors of the 1999 breakthrough book, To Err is Human. Let's go through some of this together. And again, we're still in part one, the size and scope of the jam that we're in. So we know that there's massive variation in clinical practice. We can reduce this to inappropriate clinical variation. If we could reduce inappropriate clinical variation, boy, we would be on the road toward reducing waste. High rates of inappropriate care, unacceptable rates of preventable care-associated injury and death. That's right, dreadful. Striking inability to do what we know works because of all kinds of structural and organizational impediments, and huge amounts of waste that lead to spiraling prices that then in turn limit access to care. This is not new news. This is over a decade old already, but the work that Dr. Brent James and others, people like Don Berwick, Robert Wachter, Peter Pronovost, Paul Batalden, an army of super smart physician leaders over the last decade have contributed to our understanding of the size and the scope of unexplained clinical variation. I was trained one way, that's the way I do it. You were trained your way, you get the idea. Next slide. So again, here's, we have to understand this is not only an inpatient problem, since so much of radiology is done in the outpatient setting. This is not just an inpatient issue. Here's some work from a little over a year or so ago. The quality of outpatient care, looking at a decade's worth of findings. What do we know? What do we discern from here? Well, colleagues, it's a sad story. There are lots of errors occurring in the ambulatory setting, having a lot to do with medication administration, dropped ball, failure to follow up on a positive test. This failure to follow up on a positive test is one of the most important areas for improvement in radiology, just to try to connect the dots with our audience. Next slide. Well, this is an actual picture I took in my general internal medicine practice. It's not HIPAA compliant, but we only have patients' names here. You can't tell who they are, but what do you think of this? And how about that white out standing next to the tissue that the medical assistant has written the names of the folks who have contributed these two different urine samples. So just imagine when I see a picture like this that I took in my own internal medicine primary care practice, this to me is a red signal, a flashing light. Stand by, error is about to occur because of the poor system here of this patient on the top versus Michael's at the bottom. And what you couldn't possibly know is one of these individuals has 2+ proteinuria due to diabetes. So which patient is it? And are you confident that the right patient will get the appropriate test allocated to them and the results will go to the right chart? Well, I think it's about a 50% probability that this system will fail. And you now understand a little bit with this amazing photo that I took in our own practice of the complex systems nature of care, even when it relates to something seemingly as basic as getting an ambulatory urine analysis. Next slide. So with regard to the evidentiary basis, I'm not going to get into a fight with our cardiology colleagues, but look, right before the pandemic in the late fall of 2019, in the New York Times, they were just reporting on the American College of Cardiology meeting, drugs are shown to lessen the need for surgery to fix blocked arteries, meaning of course, that we probably do too many stents and that the selection criteria for stents are constantly evolving, and that the question, why are we putting in a stent in the first place, still is an important question that needs to be asked. And in the literature with regard to stent utilization, not only by outstanding national reporters like Gina Collada, but within the cardiology community, of course, there's controversy at the very least. At about a third of all stents, we could say, gee, what was the thinking? So from low-tech urine analysis to high-tech stents, what's the message? The message here in part 1, unexplained clinical variation. Everywhere but your hospital and mine, this is an important challenge. Next slide. So let's summarize. Unexplained clinical variation, which has been around for decades, dating back to Ernie Codman a century ago, is a major roadblock to our ability to lower costs because it's overutilization. It's a roadblock to improving quality because we're tracking stuff we ought not to be tracking. And going back to our colleagues who created the American College of Surgeons in 1918, it blocks our ability to promote transparency and establish accountability for who we are and what it is we're doing. Another way to look at this, colleagues, is we need to look in the mirror and have a healthy dose of self-evaluation and measurement, just like Ernie Codman did in the immediate post-World War I era. So I can't see you, but raise your hands if you enjoy a vigorous daily 1/2 hour dose of in the mirror self-evaluation. That's a difficult question. So this is a leadership issue for the leaders in academic radiology, that you have to teach this to the next generation so they'll be willing to undergo, with appropriate guardrails, a rigorous self-evaluation. Next slide. Well, sadly, even in late 2019 with brand new books by our colleagues Wares and Sutcliffe, who are famous, of course, in our field of quality, a brand new book still not safe. And so again, for the naysayers who believe that, we have fixed the quality problem, I am here to tell you, sadly, that that's just not the case. So the arc of history from Ernie Codman to Bob Wares and Kate Sutcliffe, covering nearly a century of work, we still are in a rudimentary stage with regards to self-evaluation, measurement, accountability, and transparency. That's a key take-home message. Next slide. Finally, our colleague Marty Macri and others at Johns Hopkins, of course, took the 1999 Two Errors Human report, reevaluated it in the summer of 2018, and here's their classic British Medical Journal paper. I know it's controversial, but I believe in Marty's work and the work of his colleagues. Medical error, the third leading cause of death in the United States at last analysis, 400,000 preventable deaths. 400,000 preventable deaths due to medical error. It's a very sad state of affairs. We've made modest progress, and I think this is a very important challenge that we all face as clinicians. Next slide. So believe it or not, this is a Wall Street Journal cartoon, and it's a little hard to read, but it says, and the guy looks sort of like a nail, and he says, "Sorry, I'm a little jumpy. When you're a nail, everything looks like a hammer," which is, of course, the age-old clinical saying, if I have a hammer, everything looks like a nail, meaning if I have that cool new radiology tool, I have to amortize the cost and I'm going to use it. Colleagues, when some of my medical school classmates from Rochester, who I won't name names, got their own MRI machine and their own head CT scan in their practice, well, let's just say utilization increased for sure. So when you have a hammer, everything does start to look like a nail. Okay, next slide. So let's go to part 2 as promised, and here we're going to connect the dots. We're going to define population health. I'll give you some academic and pragmatic definitions. We're going to connect that learning to value-based care, how we're going to overcome the challenges of waste in the system. And all of this, of course, is devoted to shutting off the faucet rather than mopping up the floor. More on that in a moment. Well, I hope you appreciate this wonderful picture. I borrowed this from the leaders of Bay Care in Tampa, Florida. It's an amazing, great picture. Here's the hapless house officer. He's precariously balanced on these 2 canoes. And of course, the canoe on your left, historical and current fee for service in that red REI backpack. And on your right, value-based payment, population health management, all of which we're going to define in a moment. And he's got 3 choices, I think, if you look carefully at this photo. 1, he could jump in the canoe on your left and sail off happily into the future, except as you and I know, about 100 yards downstream is a 1,000-foot waterfall, and he is going to perish. A second choice, he could just jump in the drink and call it a day and retire. And we have seen, most especially in the last 5 years, unprecedented retirement of doctors like yours truly, just a few months away from Medicare. Or after learning about transparency and accountability and population health and the road to value, maybe he'll jump in the canoe value-based payment and population health management, recognizing that this is the pathway, if you would, the road, and in this case, the stream to redemption. And we're going to define our terms, give you some examples, both pragmatic and academic. Okay, next slide. So here is I think the key moment for me, going back to February 27th, 2017, a front page story in one of our most important medical journals, of course, USA Today. And I think this story, page 1 story, hospitals look to profit by keeping patients away, about our colleagues at Christiana Care, a big 900-bed academic medical center just south of Jefferson in Delaware. I think this story, which wasn't so much about Christiana, but was about the movement to keep people out of the hospital. In other words, to go upstream and to focus on health and wellness rather than downstream and constantly mopping up the floor. Instead of building another bariatric surgery center, why don't we try to promote nutrition and exercise? Instead of building another cardiac catheterization laboratory for stenting, let's go upstream and shut the faucet and improve nutrition and reduce food deserts and get people out the door to lose weight and exercise. Difficult social determinants of health that get into the medical system. So February 2017, 3 years ago, more now, I think is an important date because it was the first time in a general newspaper that folks began to understand that facilities are rewarded in a host of ways to keep more people healthy. The most important tool here, realigning the economic incentives to go upstream and shut that faucet rather than mopping up the floor. Next slide. So the other problems that we face of a societal nature, before I can define population health, we have to confront some other really difficult issues. This is, of course, the Institute of Medicine, now the National Academy of Medicine report. Maybe you read it. U.S. Health and International Perspective, Shorter Lives, Poorer Health. Look, here's the punchline. You've heard aspects of this before, I'm sure. We spend about a little over $3 trillion a year. This is $10,000 per person annually, including children. And for this unbelievable spending, 20% of the GDP, nobody in the world comes close. We don't rank in the top 10 health-related outcomes despite this spending. And we have 400,000 preventable deaths every year. And then finally, the subtitle of this slide, Shorter Lives, Poorer Health, what does that mean? My millennial children will have a shorter lifespan than their baby boomer mother and father, pre-pandemic. This epidemiologic fact, for the first time since the end of the Second World War in 1945, no generation has faced this. In other words, we're staring down, even pre-pandemic, a shorter lifespan for the next generation. Well, I don't know about you, but I'm pretty frustrated by a book like this and work like this, and I have spent the last decade struggling mightily against this. And I hope you'll join in the fight by thinking about and embracing the tenets of population health. More about that in a moment. Next slide. We also know that it's not about health care spending, utilization of test procedures. It's about spending on health itself. Health in this context is daycare, helping working parents, Head Start, Meals on Wheels, expanding access to preventive care, all of those socially driven issues. So if you look at this fascinating piece of work by Elizabeth Bradley and her colleagues, now she's the president of Vassar College in Poughkeepsie, New York. But Elizabeth and her team are largely responsible for articulating the connection between health and social spending, not health and health care spending. So we need to build this bridge between health care and health. Punchline here, it's all about social spending to promote health. Whereas in our country, right in the middle of this slide, we're all focused on health care spending, utilizing healthcare services. Next slide. What does this result in? This crazy patchwork quilt, $3 trillion wasteful and sometimes dangerous system? Well, sadly, this is Philadelphia. My office is sort of right at the bullseye of where those two main streets cross. And this is publicly available work. This is the Robert Wood Johnson Foundation and the Virginia Commonwealth University, our colleagues there. And this is to illustrate that if you are lucky enough to be born in Society Hill, Philadelphia, 3 blocks from my office in downtown Philadelphia at Jefferson, where I haven't been in 4 months. Amazing. If you're lucky enough to be born in that zip code, your life expectancy is 88 years, just as it says in this slide. If you get in a taxi with me and go to North Philadelphia, not too far from Temple University School of Medicine, about a 5-mile taxi ride, your life expectancy based on that zip code is 68 years. So we've got 68 from 88 is a 20-year disparity in lifespan based on zip code, which is why we say in population health, sometimes your zip code is more important than your genetic code in helping us to understand what your life expectancy is. Quite frankly, colleagues, I really need two numbers, your zip code and your credit score, and I can give a pretty accurate prediction of your life expectancy in America, where zip code is destiny, and where poverty, using zip code as a proxy, where poverty in our country means if you're poor, you are essentially unhealthy. A dreadful, dreadful connection. Next slide. So here's the original definition of population health, the conceptual framework. We owe this work to Dr. David Kindig and his colleagues. He's still alive, very much so, and working at the University of Wisconsin in Madison. Let me quickly go through this. So Kindig, in a 2003 paper in the American Journal of Public Health, we give him credit for coining the term population health, and there were others, but Kindig probably deserves the credit here. And here's the conceptual framework. Let me quickly go through this with you. So there are health outcomes that are distributed within a population, including morbidity, mortality, and quality of life. You're all familiar with these. There are determinants that drive these outcomes, like medical care, the laying on of hands, socioeconomic status, read their zip code, and genetics, that is, if you could choose your parents wisely. And then there are policies and interventions that influence the determinants that have an impact on the outcome. Social policy, Obamacare, environmental policy, climate change, and individual behavior, of course, plays a role. Main message: what is the contribution of medical care, the laying on of hands, to the health of the population? That's the key take home here. Next slide. This is another way, if you don't understand pop health and public health, I'm not going to spend more time on this. It's easy to go through it. They are not exactly synonyms. Population health is just a broader term that takes into account quality, safety, health economics, outcome measurement, but public health is still the central tenet of population health. Next slide. Here's the take-home message. So we have a mismatch in healthcare investment. In our country, on the left, that's US spending on what makes us healthy. Well, as you can see, it's pretty modest spending. Most of it goes towards medical services. What we really ought to be spending money on is on healthy behaviors and the environment and access to care. That is what makes people healthy. Another way to look at this, next slide. So what is population health management then? Well, population health management understands that the contribution to health is about social spending, reducing crime, improving education, reducing poverty. And population health management says, let's exactly connect the dots. This is a page from a Humana Corporation briefing book. I have permission to show you this from a number of years ago. And it literally, why I like this, it's literally connecting the dots. Population health management is connecting the dots among prevention and wellness, chronic care management, cost and quality outcomes, appropriate referral, like for radiologic services. In other words, if we align the economic incentives, and in this case, the incentive is capitation, a monthly fee for the care of the patient, all of a sudden we begin to align the incentives and we become more circumspect in our testing. And we become more patient-focused in asking the question, will this test make a difference in the care we deliver? Will this radiologic procedure give us information that will change our clinical decision-making? A cornerstone of radiologic practice for sure. And of course, I can't answer this on an every case basis, but what I'm suggesting and the literature supports certainly would fill the room I'm sitting in. It's a tough issue. When we connect the dots and practice population-based management with an attention to going upstream to shut the faucet rather than mopping up the floor, we actually improve outcomes, improve access, lower costs, and improve patient satisfaction and keep people appropriately out of the hospital. Next slide. So look, I didn't create this, but here is our best-selling textbook now used in 165 graduate school programs nationwide, thanks to my colleagues, Alexis, Ray, and Billy. This is the third edition of our textbook after we opened the doors to our College of Population Health now more than 10 years ago. Next slide. This is the cover of our journal, Population Health Management, the only peer-reviewed, Medline indexed scholarly journal in the field that I've had the privilege of being the editor for the last 15 years. And I hope you'll become a contributor and a follower of the kind of work that we do. Next slide. And now let me try to connect the dots between population health management, population health, and part one, how do we get out of the jam that we're in? And this all goes back more than a decade now to the work of Don Berwick and Tom Nolan, who in 2008 coined the term the triple aim. Maybe now you know the quadruple aim. So what's this all about? So the triple aim, when it was first articulated at the Institute for Healthcare Improvement by Drs. Berwick and Nolan, said the following. We have three key goals for the future. One, improve the health of the population. Well, we certainly resonate with that. Two, reduce per capita cost in healthcare by reducing waste. And three, improve the individual experience of care. And four, now, reduce doctor burnout. Let's do that again. One, improve the health of the population. Two, reduce per capita cost by reducing waste. Three, improve the individual experience of care. And four, reduce practitioner burnout. So the connectivity between the quadruple aim, population health being a cornerstone of that, and population health management is how we're going to move toward implementing the goals of the quadruple aim. There's a really important notion here in part two. Next slide. Some of the challenges in this sort of work, really a topic beyond the Lucy Squire lecture, is look, we can't even agree on what some of the population health measures are. I won't go through all 5 of these. Let's just say within the House of Population Health, we share some of the same challenges as the House of Quality Measurement, meaning what are the best measures to demonstrate that we're improving the health of the population. Here are some of the leading measures. I'll simply say, pick the ones you like and pursue those. These all have a solid research basis lying behind them. Next slide. This is a quick summary of population legislation. I know some of you are experts, some of you are in accountable care organizations. Perhaps you're even thinking about creating a primary care first organization, or you're in a risk-bearing ACO. I think this just reminds me to remind you, we're 10 years into it. That's right, the Affordable Care Act, March of 2010. We're more than a decade on into trying to change the economic incentives to drive a change in clinical behavior. The research evidence is mixed here for sure. Not every model is working, but what we do know is irrefutably, when we change the economic incentives, we change clinician behavior in the correct direction. That is to go upstream and shut the faucet rather than mopping up the floor. Next slide. So what about that individual behavior? Next slide, please. It's a little sad, but here he is. And let me give attribution to Sue Denser, who borrowed this slide from. This is, of course, Michelangelo's David, but this is the 2020 pandemic version of Michelangelo's David in Florence, Italy, of course. And this is for me to remind you that, yikes, 40% of all women in the United States over 18 are obese. You heard me right. And 30% of all men. Next slide. So here's a quiz. I wish we were together so I could see your reaction. So there's two references here. Let me quickly give them to you in Annals of Internal Medicine, now more than almost 14 years ago. And then in the summer of 2018, University of Oregon, Eugene, published in Mayo Clinic Proceedings, two papers, more than a decade apart. Here's the question. What percentage of all adults do the following 5 things? There's no partial credit. You got to do all 5. Here we go. Exercise, don't smoke, eat their fruits and vegetables like their mother taught them, wear a seatbelt, and number 5 will say close to an appropriate body mass index. So one more time, you got to do all 5 things. What percentage of adults, based on these two research papers a decade apart, what percentage of adults in 2020 do all 5 of these things? Colleagues, are you ready for the answer? Drum roll. The answer is 3%. That's right, 3%. So if you're going to be at economic risk for this sort of behavior, yikes, what do we need to think about? We need to think about changing the entire medical school, pharmacy, and nursing education. Let's talk about physiology of exercise, addiction, behavioral economics, all the things we were never taught in medical school. Let's talk about how do we actually change human behavior to influence this 3% and get this number up to a respectable level. How can we manage the health of a population when 3% of the population is really managing its own health? Let's not even think about our current challenge of wearing a mask, social distancing, practicing appropriate hand hygiene. My goodness. And you and I know if 60% of people wore a mask that was 60% effective, we would crush COVID-19. That's right. Okay, next slide. So the other social determinants of health, which fill your hospital and mine right now, are smoking, unhealthy diet, closely linked to physical inactivity, and alcohol abuse. Right now, that's 40% of all deaths across the 14 hospitals that I'm proud to be a part of Jefferson Health. So behavior, remember the 3 types of waste: individual behavior, clinical waste, administrative waste. We have a long way to go in helping people to overcome these issues. Next slide. Well, what does this all boil down to when you try to connect the dots between going upstream and shutting the faucet, chronic disease, population health management? So look at this incredible headline, not about Bryce Harper and Father's Day a year ago. Look at this incredible headline, a worrisome rise in amputations. Here's how it works in the great city, the founding city of our nation, Philadelphia, home of 5 medical schools, including the 2 largest private schools, Jefferson and Drexel. Here's how it works. We have a minority population that's more than 55% of our population is Black. They have a disproportionate suffering of type 1 and type 2 diabetes, but we're mainly talking about type 1 here. So the system failure is that these patients end up with a worrisome rise in amputations. Instead of going upstream to shut that faucet and having education, diet, appropriate access, appropriate treatment, we have downstream treatment, which in this case is a worrisome rise in amputation. Colleagues, this headline says we have failed. It's a failure to implement the basic tenets of good population health management. The reasons are complex, some social, some clinical, some economic. And in this toxic brew, we end up with a worrisome rise in amputations. Next slide. So some people believe we're in the straddle of these 2 curves. I don't have time to go through all of this, but I hope you'll take a careful look at this. We've passed through the first curve. We're not talking about COVID now. The first curve of fee-for-service, standalone providers. We're in this straddle area. Who knows what we'll look like when we come out of COVID, but we're probably in what many experts have called this second curve, which is going to rely on value-based payment, systems of care, the centricity of the information technology. That's where all of you come in with regard to radiology and the systems of care that radiology represents. What's the data that you're going to use to make sure we're making the appropriate radiologic diagnosis and appropriate radiologic use of precious resources? Next slide. So let me end part two with a great story. This is, of course, the great Commonwealth of Pennsylvania, in case your geography is not so great. We have 67 counties in our wonderful state. And here they are using the same data set that we used from the Virginia Commonwealth University. Remember that one of the disparity in life expectancy? So here we are ranking the health of the population in every county in Pennsylvania. There are 67 counties. So if you're ranked 1, you're the healthiest. And if you're ranked 67, you're the least healthy. So take a careful look. That's right. Philadelphia County, home of the 5 medical schools, because Philadelphia, the city, is in Philadelphia County. So colleagues, I'm embarrassed, chagrined to tell you that the College of Population Health at Jefferson is in Philadelphia County, and our county is ranked dead last as the least healthy county in our great state. So what's population health? Sorting out this mess. Okay, next slide. So I believe we're at the Malcolm Gladwell tipping point, that with physician leadership, radiology leadership in particular, we can embrace the notion of population health management, realign the economic incentives, and become, like in 1918, accountable and transparent in what we do. Let me show you some thoughts for the future, and we'll summarize in the next 10 minutes. Next slide. So I think there's a checklist. We're not going to go through all of this today. Here are some thoughts for your own organization to think about. Who is taking care of our own employees? What are we doing to keep people who are already healthy? My favorite is number 7 there. What are we doing about physician leadership training beyond a great program like I'm privileged to be a part of today? How are we building the leadership team for the future? Big topic for another time. Next slide. So here's the president of your medical staff. This is a boy deer due to the antlers, and he's like a deer in the headlights. That's right. And here are some of the challenges that he's going to face here in part 3, our final part together, talking about the future. Next slide. Here are the challenges that remain. Well, way back to 1918, we're focused on transparency and accountability. And our college coined the phrase nearly a decade ago, no outcome, no income. Or if you prefer, poor outcome, less income, but for us, no outcome, no income, meaning it's all about being transparent and accountable in our attempt to achieve value for what we're doing. A good outcome at a good price. And this is not only good business, it's good medicine, of course, because it avoids unnecessary utilization and it avoids error that can cause harm. Next slide. How do we get there? Well, again, this is just a summary, and I won't go through all of this, but I'll highlight the things that you and I have chatted about. Certainly, the most important thing here is number 2, reducing unexplained clinical variation, using guidelines, protocols, registries, feedback from our information technology, the software, the analytics that we need. Does this patient really need a PET scan? And how will it change what we're going to do with and for them? These are the tougher questions that radiology leaders will need to be asking and teaching about the next generation. Next slide. So we're going to skip this one. Go to the next slide, please. So what about the future? Well, I don't have the time to get into every detail about connectivity with the consumer, but I do want to leave you with some sense about where we're going with connecting with the consumer of the future. Wouldn't it be amazing if they had this sort of crazy on-off switch? But next slide will illustrate where we're going. So I think we're going to see unprecedented transparency and accountability. Certainly my millennial children would never go to a doctor's office or a hospital without checking the Yelp reviews You and I of a certain age may not think that's important, but we know that this kind of transparency and social connectivity is going to be more important over time, and that when you engage with the population, you have a much higher probability of improving their health and expanding on that 3% of individuals who are doing all the things we articulated a little while ago. Next slide. I also know that in the AARP magazine, we have folks who are tracking all of their physiology, the so-called self-quantifiers. This is a fantastic picture with all the available technology. I would encourage you to read the work of Bob Wachter, the digital doctor, Eric Topol, Marty Macri, and our colleagues who have written extensively about the connection between all of the new technology, digital health, and getting patients engaged in their own health using these tools. Next slide. There's a scholarship involved in this. The same folks who publish our journal, Marianne Liebert, Pop Health Management, publish Games for Health and the journal Big Data. So this has become an area for appropriate research and scholarship looking at these issues. Next slide. You've read about that if we can get folks to wear that smartwatch and close the feedback loop with their practitioner, companies like Livongo and Color and Commure and other Mindstrong and others who are working hard to do what Steve Klasko, our leader at Jefferson, calls creating unhealth care, creating health assurance by focusing on the fact that care is always on, and that we're constantly in communication with our caregivers using these tools. This is not a futuristic vision. This is a vision we can achieve today with appropriate financial incentives. Next slide. So look, my vision is, Alexa, refill my omeprazole, and then the drone is going to come to your house, and because the drone comes from Whole Foods, not only are you going to get your omeprazole, but you're going to get, recipes for low acid reflux food. That's the vision of the future, already available in some markets. It's truly unbelievable. And what's really unbelievable, next few slides. So look, we didn't invent this. Kaiser Permanente, I love this advertisement. Call in, click in, or come in. And of course, you and I know in the last 140 days, we've had more social change as it relates to telehealth than in the previous 5 years. And I don't even like to call it telemedicine or telehealth. We don't call it telebanking. I like to call it virtual health, that there's all kinds of ways now to access the system. And radiology, goodness knows, you folks are going to be at the lead of click in or call in or come in as you harness all the new technologies of the future. Next slide. Some of this technology is just incredible. We don't have time to talk about it today, but there's new technology to evaluate tone and voice, be able to make some predictions based on deep predictive analytic tools. Next slide. And soon we're going to see the rise of robots in healthcare. I predict radiologists will be all over this. The robot will see you now. Time magazine cover story. Hope you like this one. Next slide. Talking to robots, a deep scholarly evaluation from the MIT Robot Lab about the interface between humans and robots and what that's going to mean. I think radiologists are going to be at the cutting edge of this kind of activity for sure. And we're going to deliver robotic radiologic services deeper into the community, acute care in the home. I believe we're not too far away from this already. Next slide. And then finally, a great example already in use, and this is from the Wall Street Journal, not the American College of Radiology, on-demand grandkids and robot pals to keep senior loneliness at bay. Go to the next slide. I'll show you what we're talking about here. So here is, I love the title of this story, For Real. Get it? Yuck, yuck, for real. So this is Brown Medical School and Hasbro, both in Providence, Rhode Island. And this is scholarly research at Brown Medical School about reducing loneliness, which is an epidemic, most especially exacerbated during the pandemic, of nursing home bound elders. And when they have this robotic cat, it reduces their level of loneliness. Now, what if we were to get Alexa inside that cat? We could have a conversation, we could deliver medication, she could carry on a conversation. Unbelievable, the technology that we are creating to reduce the epidemic of loneliness among the elderly. A very important social determinant of health and wellness. Next slide. So, clinician burnout, certainly a gigantic topic. Part 4 of the quadruple aim. What's the research evidence? Here's the connection. When we give doctors tools to tackle those pesky social determinants, a prescription for food to give to patients, transportation for patients, greater access to radiologic services for patients, when we reduce those social impediments to care, and when we improve access, we reduce doctor burnout because we're able to do our sworn duty to improve health, to go upstream and shut that faucet rather than always mopping up the floor. I'm optimistic about our ability to harness technology to improve this. Next slide. So let me leave you with my closing thoughts. Here I am boiling the bones of medical staff members who disagreed with me, so be careful. And hopefully you know where this is, at the beautiful gardens outside of Princeton, New Jersey. Next slide. So colleagues, a couple of thoughts to close here. The medical staff elected rotating leadership structure that was first built the year I was born, 1955, to preserve physician leadership back, a century ago. That rotating medical staff leadership structure is an anachronism. We need real expertise. We need skill sets in physician leaders. So kudos to the AUR for training the radiology leaders of tomorrow, because that's what real leadership is all about. And I'm just a teeny piece of this with this wonderful Lucy Squire lecture and all the other things you're exposed to. But I would argue that this rotating staff leadership kind of craziness, you know the old gag, and it still is apropos today. You're the new medical staff president because you missed the last 3 medical executive committee meetings. Is that the leadership structure you and I want for the rock'em sock'em crazy future that we're all facing? Next slide. Well, I think the hospital of the future should be the big H for health. And I want you to think about this paradigm shift that H, yes, not only represents hospital, but it's health and it's healing and it's hope that we're going to align the economic incentives, reduce unexplained variation, embrace the tenets of population health. That is what's making me hopeful, another H for the future. Next slide. So the private sector gets this, and this is, of course, just a diagram to remind me, to remind you that those private equity firms are pouring billions of dollars of private equity money into our industry. How come? Well, they know that $3 trillion, if they could get 1% of that, reduce that waste 1%, that's a pretty good margin for a new business. So the other thing that makes me hopeful is the private sector entrance into healthcare, bringing us all of their new ideas. Organizations, for example, like General Catalyst, led by Himantanaja and others, there's a score of private equity firms that are making important contributions to our future. And I want physician leadership in every one of these firms, radiologists in particular. Next slide. So 1 minute of shameless advertising to close out. Let me summarize where we were. Thank you for joining me. Thank you for giving me the privilege of speaking with you and for taking time out of your busy schedules. Kudos to Lucy Frank Squire on her incredible pace-setting career for people like my daughter, who's a physician now. I hope you'll join us online for any one of our amazing online master's degrees. I'm incredibly proud to have been the founding dean of America's first College of Population Health. Grateful for the opportunity to celebrate my 30th anniversary on the faculty at Jefferson. And I'm going to leave you with the notion that I hope you'll join us for any one of our amazing online programs. I think today in particular, our program in quality and safety and our program in population health. And let me leave you now with the final slide. And as I've already noted, this is, of course, John Cotter from Harvard Business School, author of 36 books on leadership. Kudos to AUR, because the leaders of today know that one of their key responsibilities, key attributes is building the leaders of tomorrow. And that's what I see my role here with you today in helping to educate the next group of amazing leaders within radiology who are going to embrace the tenets of improving the health of the population. And where we were an hour ago, shut that faucet instead of mopping up the floor. And in conclusion, in case you're wondering, what was that famous battleship coming out of the Brooklyn Navy Yard in 1918? Of course, colleagues, that famous battleship was the USS Arizona, torpedoed on December 7th, 1941, of course, in Pearl Harbor, Hawaii, entombing 2,000 sailors, and that brought America into the Second World War, a ship that is an important part of our history. In 1918, the formation of the American College of Surgeons and the beginning of our discussion of transparency and accountability. Thanks again for joining us. I am really privileged to be a part of this program. All the best.